Everyone, welcome to the webinar on treating recurrent focal segmental glomerulosclerosis in kidney transplant recipients, sponsored by Caneca Medical America. I am Nicolae Leca, transplant nephrologist from University of Washington in Seattle, and it is my pleasure to introduce our speaker today, Dr. Tarek Alhamad, Associate Professor of Medicine at Washington University in St. Louis. Dr. Alhamad is a transplant nephrologist and serves as the Medical Director of Transplant Nephrology at Washington University. CME credits are available for this webinar through Opus Medicus, who designates this activity as one AMA PRA Category 1 credit and one American Board of Internal Medicine Maintenance of Certification point. Please feel free to submit questions at any time through the chat. There will be opportunities to answer them after the formal presentation during the Q&A session. And now I'll pass it on to Dr. Alhamad.
Thank you, Dr. Leca, for the introduction and for moderating this session. Recurrent FSGS continues to be a challenging medical problem in the field of transplant. And I hope through these slides that we could touch base on some of the etiology and management of this clinical problem. So I would like to start with a few questions. I just want you to think about some answers, keep that in mind, and then we'll come back to these questions at the end of the presentation. For kidney transplant patients with recurrent FSGS, which one is accurate? Recurrent FSGS is not associated with graft failure. Recurrent FSGS has better survival than de novo FSGS. Recurrent FSGS is associated with an increased risk of graft failure. Which one is not a risk factor for recurrent FSGS? Prior recurrence, elderly patients, short period between diagnosis and starting dialysis, white recipients, pre-transplant bilateral nephrectomy. Last question. Which one of the following is a treatment option for recurrent FSGS? LDL apheresis, rituximab, ACTH-gel, plasmapheresis, all of the above. And I would like to start showing a couple of slides on the magnitude of this disease, recurrent GN, and focus a little bit on FSGS. So this is a distribution of adult patients on the kidney transplant on the waiting list by diagnosis. And this numbers has been pretty much the same over the last 10, 15 years. And we could see that in the red line here, that GN, end stage renal disease connected to GN, is around 30% of the etiologies of kidney disease. So this is something common that we deal with frequently. This is in terms of numbers, and this is by the total kidney transplants, the patients who were attributed to have end stage renal disease connected to GN was around 3,500, and this number continues to be around these numbers, 3,500 patients per year. We know that recurrent GN could impact kidney graft survival. This is one of the studies that looked at different types of GN, and here in the left side, there are the different type of GN, and I highlighted here by 2 arrows the actual graft survival here. And we could see that the 2 lowest graft survival is FSGS and MPGN. MPGN probably also at that time of the study, that was probably 2017, they also included atypical HUS C3 as part of the MPGN, so it has actually way lower survival. But FSGS is probably the second lowest disease that impact graft survival among recurrent GNs. This is the same study, but with a different figure. We could see that the hazard ratio for graft failure was 6.74 MPGN and 4.9 for recurrent FSGS. This study looking at the difference between the impact of recurrent versus de novo FSGS. And as you will see in most of the studies that we will be reviewing today, similar to the field of nephrology, we have an issue with the number of patients. And this study included 33 patients, small number, and they looked at graft survival between de novo and recurrence. In terms of recurrence, graft survival at 5 years was 57%. And that was through a Kaplan-Meier survival curve, and was 82% of de novo. So when we think about recurrent FSGS or de novo FSGS, what are the issues that we have in terms of that classifications? Now, we know that many patients get their kidney biopsy quite late in their progress of kidney disease. Many cases are attributed to hypertension and secondary FSGS, whereas in reality, it could be actually primary FSGS. So there are an issue of maybe underestimation of this disease prior to transplant. And the other thing that many patients don't have a biopsy before transplant. They may present quite late, and they are just starting dialysis. They don't have a good follow-up before transplant, and we don't know exactly what is the primary disease. FSGS remains a descriptive disease. Basically, we are looking at the light chain, at the light microscopy, and we are deciding that this is an FSGS based on the focal segmental sclerosis, regardless of the etiology that is leading to this manifestation. And there's a major issue of the lack of diagnostic tool that could lead us to what type of treatment option that we provide for a specific patient. Saying that, these are the possible etiologies that we have been considering in the last several years for FSGS. There are some evidence that FSGS could be related to a circulating factor, whether this is SUPAR or a different protein or different molecule. We have seen patients respond to plasmapheresis. So this might be a strong, not a strong evidence, but maybe a good clue that a circulating factor might be a reason for a good number of patients. What's the impact of other cells in this equation? T cells, B cell, and the response to rituximab in few studies, as we will see. So there are several theories behind the etiology of FSGS. At the end of the day, all have the same end result, impacting podocyte that would lead to loss of nephrin and podocin and effacement of podocyte, which should lead to the proteinuria and graft dysfunction. This is based on prior epidemiological studies looking at risk factors for recurrent FSGS. Factors that have been shown to increase the recurrence of FSGS include recurrence in a prior kidney. So overall, the rate of recurrence in the first kidney is probably 30 to 40%, depends on the study that you are reviewing. But if you have prior recurrence, the chance of recurrence in the second or subsequent kidney transplant is very high, 90, maybe up to 100%. Younger patients at the time of diagnosis of FSGS, short period between diagnosis and starting dialysis is just a hint for how the disease is severe. Higher proteinuria, pre-transplantation or at the time of diagnosis, white recipients, and pre-transplant bilateral nephrectomies, which is also could be taken as a marker of severity of the disease that has led to nephrectomy. But I don't think that the nephrectomy itself has any impact. It's just a marker, just a marker of severity of disease. The Columbia classification a non-nephrotic pre-transplant and familial FSGS have not been shown to increase risk for recurrence. The question that comes to our mind, are we able to prevent the recurrence of FSGS? Could we do something before transplant that could prevent the recurrence? I would like to use this study that was published by the group in Hopkins, led by Sami Al-Asfar in 2018, titled Rituximab and Therapeutic Plasma Exchange in Recurrent FSGS. And I've taken this actually from the paper. So they included 37 patients with FSGS received preventive therapy with TPA, plasmapheresis, and or rituximab, and compared to 27 patients. So that's small, relatively small, but that's a good number of patients in terms of our studies for FSGS. And showed that preventive therapy, that was the conclusion, preventive therapy don't decrease the recurrence rate of recurrent FSGS. However, promote treatment of recurrent with this therapy may result in improved outcomes. We, in our center, we have done also submitted an abstract before, and we showed that rituximab does not prevent recurrent FSGS. However, we still use rituximab in primary FSGS as sort of a hope, when you don't have much measures to do to prevent that, you just like try to do something, you feel that you are doing something. So we still give a low dose of rituximab to prevent FSGS without an evidence that this actually is helping our patients. Treatment options. Plasmapheresis is one of the treatment options. There are several studies. Most of them, as you could see here, include small number of patients. Overall, plasmapheresis have been shown to improve the response or lead to response, whether it was partial or complete response, by around 63% in adults. Rituximab, we'll go a little bit in details of this study. This study included 39 patients with FSGS with nephrotic range proteinuria. 34 out of 39 had biopsy-proven FSGS. Patients were on standard immunosuppression medications, TAC, MMF, and prednisone. And if you look here in this to this table, table 1, we could see that the age of diagnosis was quite young, like 6, and the age of transplant was 18. So this, although there's a range between 5 and 48, but this was like an actually pediatric study. One of our colleagues in WashU, Vikas Darnidarka, was one of the co-authors. The clinical recurrence occurred in 71% of patients in the first week and 74% in the first month. So quite higher recurrence that we see in adults. Outcomes, 43% achieved complete remission, which defined of proteinuria less than 0.5 gram, and partial remission defined of proteinuria less than 3 grams, 20%. So overall, combined complete and partial, they were like around 65% of response, which is a good response overall. A follow-up study was done, or a case series by Dr. Vicente and other co-authors. They included 4 consecutive adult patients with early recurrent FSGS that were refractory. They were refractory to plasmapheresis or dependent on plasmapheresis. And they reported that none of these patients treated with rituximab. And throughout the next few slides, you will see that this is something can be a little bit of a trend, that some studies showed an improvement, other studies showed no improvement, which reflects the fact that FSGS have different etiologies. That's why, based on the cohort, there are different responses among patients. Cyclosporin. Not many transplant centers are using cyclosporin anymore. whether it was a standard therapy or for treatment of FSGS. This study, I would like to highlight this, one of the studies here at the end of this table by Canoud. I think that was a French study, but I'm not sure. It involves giving 14 days of continuous IV cyclosporin, which we cannot get in our hospital, at least, to get IV CNI, followed by oral treatment targeting C2 levels between peak level between 1200 to 1400 nanogram per ml. This is quite very high level given IV. So maybe they reported partial remission in 12% and complete remission in 90%. This study have not been done somewhere else, but it looks to me quite, the cyclosporin IV is a little bit may not be needed. But anyway, we'll leave that as it is now. We'll come back later if we have any questions we could discuss further. At one point, there was some interest on abatacept or belatacept. Abatacept solution, a protein that inhibits T cell protein, used for the treatment of rheumatoid arthritis. We use for transplant, we use belatacept. This initial study included 4 patients with recurrent FSGS. The biopsy showed positive B7-1. All received plasmapheresis and rituximab pre-abatacept. After that, they received 1 to 2 doses of abatacept, 10 milligram per kilogram, and they reported that all four patients had resolution of proteinuria with variable associated plasmapheresis treatment. So with that study, the interest of using abatacept or belatacept increased in the field of nephrology and transplant nephrology. This was followed by a paper in JSON, and I just got a cut and paste the title and the end of the conclusion. P7-1 blockade does not improve post-transplant nephrotic syndrome caused by recurrent FSGS. And just reading here that they did not detect P7-1 expression by IF in podocyte of biopsy specimen from these or other kidney grafts or podocytes of native kidney biopsy specimens. In conclusion, P7-1 blockade did not induce FSGS remission after transplant in our study. Same kind of like trend of the contrast in findings between studies. I'd like this letter to the editor in Transplant International because it just shows how much therapy we are giving to these patients. And let's take patient 1, and he's 63, male, and let's look at prophylactic treatment. Prophylactic treatment that he received to prevent FSGS. We see that he received plasmapheresis, PP, or rituximab, received IV cyclosporin, and got induction with thymoglobulin. Maintenance, standard. Treatment for of recurrent FSGS, plasmapheresis, rituximab, galactose, and then they used belatacept. And you could see similar therapy in patient 2, 3, 4. So we are giving them a lot of therapy because there's basically not a very great option has been in the market. And the fact that there are different etiologies or reasons behind FSGS. ACTH gel, something has been in the light. It's an old medication, but has been in the light for treatment of GN maybe in the last few years. And the interest part of the ACTH is not the steroid part, but actually the impact on melanocortin receptor 3 on the podocytes. We had a case series, 10 cases from WashU, 10 cases from Hopkins, combined in paper in transplantation. And we use that therapy for patients with refractory patients. 4 of them achieved complete remission. We defined that by proteinuria of less than 1 gram. 6 of them partial remission, defined by proteinuria less than 3 gram, and no response, 10 patients. During that, during the paper, we were asked later to write a sort of like a flow chart or diagram on the treatment of FSGS, which I will take this as an entry to our one of the new option of treatment of LDL apheresis. So the first, I will take it from the top of this diagram here, starting that there's no strong evidence that plasmapheresis or rituximab before transplant prevent the recurrence. I think a good number of you would agree with me on this. If we have a history of FSGS or any clear etiology of kidney failure, we watch proteinuria. After kidney transplantation, we check this weekly until month 4, and then we do that monthly until month 12. If we have proteinuria, we do biopsy with EM. We rule out secondary etiologies such as viral infections, medications, pamidronate, mTOR inhibitors, interferon, or supplements such as anabolic steroids. If we have a recurrent FSGS, we start sort of like an intensive course of plasmapheresis, 3 to 5 sessions in the hospital. We give a dose of rituximab, and then we follow up as an outpatient. And usually it takes a few weeks before we arrange plasmapheresis as an outpatient. If no response, we consider using ACTH-gel. But here, as a first option, recently we have changed our approach to the treatment and start using LDL apheresis as one of the first options for treatment for FSGS. So what does this add? LDL apheresis. Now we have already reviewed that plasmapheresis would work in certain patients. And this is a famous case report or letter to the editor in New England Journal of Medicine, showed a patient who got a kidney transplant and had proteinuria immediately post-transplantation. And we could see that at day 14, that kidney got transplanted in a different recipient, and there was no proteinuria. Just to hint that there might be some circulating factor that had immediate impact on kidney transplant. On the right side, the SUPAR is questionable in the literature, but we just highlight that there might be a circulating protein, whether it was SUPAR or something else, that might be a factor in recurrent FSGS. So what does that, again, back to the question, what does LDL apheresis adds to our therapy? Well, now, just highlight a little bit of the mechanism. Some of it not very well known, but we know that podocyte injury would lead to albuminuria, and hyperlipidemia. And this increased the ratio, so we have less albumin and more free fatty acids. So that ratio increases that ratio and of the free fatty acid and get us into a vicious cycle of persistent podocyte damage. So in theory, lipoprotein apheresis could lower the lipid levels, decrease the free fatty acids, and prevent further proteinuria damage. That increase of free fatty acid will increase the circulating ANGPTL4, which has an expression on podocyte and will induce proteinuria. The exact mechanism is not very well known. But one of the other theories that will lead to excessive macropinocytosis and accumulation of albumin in podocytes, which would lead to lysosomal dysfunction and podocyte loss. There have been actually few studies looking at the impact of LDL apheresis in FSGS. I would like to highlight the last study by Hattori et al. That was published in Journal of Kidney Disease. Here we have 11 patients, pediatric patients with a biopsy-proven FSGS, and they have not been responsive to prednisone and cyclosporin. If we look at the level of proteinuria, which is almost not the final column, the one before the final here, and we could see that these patients have really good amount of proteinuria. It ranges between 7 or 6 to 14 grams of proteinuria. And we could see the serum level of albumin. They have quite hypoalbuminemia. This is the LDL therapy, sort of like standard protocol, that 2 sessions per week for 3 weeks. So this is sort of like the induction or intensive starting, and then frequency will go down to 1 session per week for 6 weeks. So 2 sessions per week for 3 weeks, and then 1 session per week for 6 weeks. Here in the figure, y-axis is the level of proteinuria, a gram per day, and then in the x-axis is basically the length of follow-up in weeks. Now there are 3-4 patients that we see here have like more horizontal line that they have not responded to the treatment. But there are other patients we see that the line of proteinuria, the trend of proteinuria goes down from a mean level of around 7, goes down to less than 2. Currently, there are an ongoing study looking for patients for to treat with LDL apheresis. The inclusion criteria include patients having FSGS with GFR more than 45 and any of the following: refractory nephrotic syndrome in which standard treatment options are unsuccessful, refractory nephrotic syndrome in which standard treatment options are not well tolerated, or refractory or recurrent nephrotic syndrome in which standard therapy is contraindicated. This include also pediatric post-transplant patients and post-transplant FSGS. So in my center, I am the PI for this study, and I treat patients with post-transplant FSGS. I have not had any pediatric in the study. The study is looking to enroll 35 patients in 3 to 10 clinical sites. They go over the inclusion-exclusion criteria, and as we discuss the therapy, 2 treatments per week for 3 weeks, followed by 1 treatment per week for 6 weeks. So this is overall actually my presentation, and I will be happy to go over if you have any questions, we'll discuss, we'll expand further. Going over these questions, they were not that hard, but just like as part of the presentation. For kidney transplant patient with recurrent FSGS, which one is accurate? Recurrent FSGS is associated with increased risk of graft failure. Which one is not a risk factor for recurrent FSGS? Elderly patients. Young patients actually have a higher risk for recurrence compared to elderly patients. And the third question, which one of the following is a treatment option? We have reviewed all of these options. As we discussed, it all depends on the etiology of kidney disease, and if this was actually hidden treatment or mask diagnosis before transplant, if it's a recurrence, or truly de novo. And I will leave this slide. This is where you can get your exam evaluation and certificate from the website. I would like to move it back to Dr. Leca now.
Dr. Alhamad, thank you so much for a very nice presentation. Maybe I can start with asking for your experience with the study with LDL apheresis. Obviously, you showed us data that this is still a very significant disease. Recurrent FSGS leads to an increased risk of graft failure, and the treatments have been variable and not a slam dunk by no means. There's definitely not a standardized treatment for this disease that we know of. Some of it may be due to the heterogeneity of the disease in a disease that's already very rare, as we know. Yeah, maybe you can start telling us what has been your, obviously we are not looking for outcomes, but how has been the implementation of the LDL apheresis as part of this study that you've been doing?
Sure. So we got a few patients enrolled in the study. A couple of them responded very well. One patient did not respond, but overall it was very well tolerated. We had to stop ACE inhibitors, so if they are taking lisinopril, anything of ACE inhibitors, we have to stop that at least a few days before. Overall, it's softer than plasmapheresis, than the standard plasmapheresis, well tolerated. And actually, we were trying to do another study to examine the actual, sort of like the actual mechanism, trying to look at the effluent fluids and see if we can get more answers on the exact etiologies. But I would say the couple of patients that responded immediately during that sort of like acute phase of treatment. So within the second or third week, they have already shown a response to LDL apheresis.
What strikes me about this disease is that despite the fact of its rarity, that there is heterogeneity, and at least in my clinical experience, which it's limited, as I suspect everyone else with this rare disease, but there's a group of patients that have a very severe and explosive recurrence with proteinuria that's extremely high, usually in post-op day 1 already, if you check it, and then there's another subgroup of patients that will have a more progressive, but sometimes even worse outcome, in my experience at least. I think sometimes we can turn around easier those with more explosive course, and a little more difficult those with the progressive course of proteinuria that maybe not as marked as in the first group, but it continues to progress and maybe associated with more renal dysfunction. I'm not sure if your experience has been similar, and if you are approaching it differently, where you have a different diagnostic and treatment algorithm that you consider for these patients.
I agree actually with your observation. Overall, the likelihood of a response to treatment is, I think it's higher when it's a little bit closer to the time of transplant. And usually also it's higher when you start treatment early. Sometimes some remote patients, they have a little bit of proteinuria. We put them on ACE inhibitors and now the SGLT2 inhibitor, and sometimes we sleep on it, and we don't do biopsy until a little bit kind of like late. So I think I agree with your observation, and I also think that earlier treatment may increase the chances of recovery rather than waiting 6-12 months before we do a biopsy and have a diagnosis.
That's
in terms, I think you also mentioned regarding the approach. It's a good question. We have similar approach to early versus late FSGS. Maybe with early, maybe you have more focus on plasmapheresis, but overall we follow kind of like similar structure. If we have if we have cases of late FSGS with a lot of fibrosis in the background, we may not do aggressive therapy with plasmapheresis. We may give a patient dose of low dose of FSGS of rituximab, but overall similar approach. I'm not sure if you have something different that you do for your patients.
Yeah, no, I agree. It's the more progressive type where we end up throwing the whole kitchen sink, and unfortunately, usually nothing seems to be working. My colleague is dealing with with a case like this currently, and unfortunately, nothing that we've done so far has helped. We would have maybe consider LDL apheresis, but the renal dysfunction is limiting. Can you maybe comment why that is? Why renal dysfunction will limit the availability of treatment with LDL apheresis?
Sure. I think with that, let me see if I could go back to that slide. Oops, I think I took that out. Okay, with recurrent FSGS in transplant, I don't think there's a certain cutoff that they have. They have the 45 for native kidney. Like if you have native kidney with FSGS, you have a cutoff of 45. In recurrence, there's no cutoff for FSGS. And even if the patient is not included in the study, you could do actually LDL apheresis without being in the study. We tried that in one patient. We just have to submit a couple of forms to IRB, but you could do LDL apheresis outside of the study if you think that it would help the patient.
But let's go back to the rituximab. I always I'm interested in people's perspectives because when you read the literature and treatments, you're always going to see this combination of plasmapheresis and rituximab. To me, rituximab is, as you know, is an antibody, so it has a half-life of about 3 weeks, as any other antibody treatment, unless it's pegylated or has other modification. But so 3 weeks of half-life, and we also know that rituximab is mainly intravascularly distributed early on, and then has, as any other antibody, a slow progression towards the extracellular space or the interstitial space, but doesn't happen immediately. So I'm always kind of skeptical when I hear this combination of rituximab and plasmapheresis. Are you not actually taking off the rituximab by doing plasmapheresis? And what's your approach? How do you approach the combination of apheresis and rituximab? And would LDL apheresis maybe be, in some cases, a better option rather than the regular plasmapheresis, just to avoid that depletion?
Sure. Good question. So how we do it usually, we do 3 to 5 sessions of plasmapheresis, and then after the last session of plasmapheresis, we give a dose of rituximab. And it has been sort of like historical here in WashU that we do a low dose of rituximab, so we give like 200 milligrams instead of the full dose, which has been shown that it's enough to deplete P cells. And when we start plasmapheresis in outpatient, usually it takes at least 4, if not 8 or 12 weeks before we are able to find a center, to get a supplier, and to get somebody to supervise plasmapheresis. So I think so let's say 8 weeks. So probably maybe we are doing a little bit of pheresis of that rituximab at the end, but I think in the initial period, 4 to 8 weeks, patient is not getting any pheresis during that time after rituximab. So that would give enough time to see if there's any response.
We do have a question from my colleague, Dr. DiCastro, who wants clarification about the study eligibility criteria for LDL apheresis with GFR more than 45. But I think you already answered that question in the sense that you said that you can use the LDL apheresis outside of the study, and for the post-transplant there may not be a GFR cutoff. Is that correct?
Yes, correct.
Right.
And I think I don't know why they have that in the native kidney, but 45 seems a little bit high to me. I know some studies they like to avoid having major kidney injury, such as like if GFR is than 15, which is probably understandable, but 45 is a little bit high not to include for native kidneys.
Well, thank you. Can we maybe talk a little bit about the etiology? What's the status of the SUPAR? What's your perspective on that?
So I'm not a big believer in SUPAR. Sorry, the sun is coming now with this sundown. I'm not a big believer of SUPAR, but I the literature has not been able to replicate the data that has been published. But I think there's in some patient there must be a circulating factor that is leading to immediate recurrence of FSGS that is leading to massive proteinuria. I think there must be some kind of like circulating factor. But I think that there's still not final answer for that. I think there are several studies looking at this. But I think plasmapheresis, LDL apheresis is quite reasonable to start with, in particular in early cases of recurrent FSGS.
How about the more recent discovery of the anti-nephrin antibodies by the Mass General group? What's your perspective? Have you had an opportunity to test for some of those and in the recurrent cases?
Yeah, we have sent to lab, but we have not examined. To be honest, we have not examined any of these results. But this is quite interesting to see the other possibility for this circulating agents or the other etiologies. I think it probably needs more than one. I think needs like a collaborative of multi-centers where we could have more cases and just like examine the impact of these different therapies and impact looking at different etiologies. But this is quite, I think it's interesting. I have not looked at the results of these in our case series.
Excellent. Apologies for that. I don't see other questions from the audience. Well, there is one that just came in from Adnan Khan. Do you have experience or data comparing apheresis versus LDL apheresis?
No, I don't think there's a data comparing LDL apheresis to plasmapheresis.
I am currently caring for a patient that had a very early recurrence that responded quite well to rituximab, and we are in well, I should say maybe I would refer to a different patient. There's a patient that had an early recurrence, responded very well to rituximab, and we've seen multiple episodes of relapse besides the fact that she responded so well. So he went in complete clinical remission with very low proteinuria. This patient is now 12 years after the transplant. During this time, she's had actually 2 successful pregnancies, which was quite amazing, but has had multiple instances of proteinuria relapse with changes of FSGS that responded very promptly to rituximab. I'm wondering if you had similar experiences with patients that have relapsed after initial complete response.
Yeah, we have actually one kind of like very known patient to our group that almost once a year, the patient would have a recurrence. Usually it comes after a viral infection or something like an admission for a different reason, and then they have a recurrent. That patient, if I remember correctly, we would give him either, I think we give him rituximab in a few of the recurrences, and then we give him ACTH gel. And he actually responded to both treatments. And usually he responds within 4 to 6 weeks of treatment. So yeah, there are certain patients who would have like complete remission, and then in a year after holding therapy, they would have a recurrence, whether it was just like without a reason or just triggered by a viral infection.
We have another question from Dr. De Castro from University of Washington here. Can you briefly tell us the technical differences between plasmapheresis and LDL apheresis? Like, what are we pheresing out, prescription, and side effects?
Right. So this is a little bit more technical question. So for plasmapheresis, you do 1 to 1.5 plasma volume. You replace with the albumin urea, with replace with albumin. Sometimes we replace with FFPs based if you have a recent biopsy or based on coagulation factors. You use the AV fistula or central line. LDL pheresis, you use also the central line, but you are not sort of like replacing the plasma. So you don't need to give albumin. You give normal saline basically for any effluent fluid that's coming out. Sometimes we add both. We give a little bit of albumin and NS, but basically what you are freezing out are some lipids, some lipoproteins, and of course have the lightweight or the lightweight. The exact effluent, what are the components? This is one of the things actually we are trying to examine here, that if it doesn't make sense of what are taking out is making any sort of like what are the exact molecule that makes a difference here. But in theory, we talked about the impact of the free acids and how the decreasing LDL, of course, the major thing that you are taking off is LDL. That decreasing LDL, decreasing fatty acids will help in the podocyte recovery. That's the theory beyond LDL apheresis. Side effects, the major one that we have seen is when patient taking ACE inhibitors, basically having sensitivity or allergy. Apart from that, it's way softer than plasmapheresis. There's no impact on coagulations or in terms of like volume status, hypotension, or overall well tolerated apart from that sensitivity to ACE inhibitors.
I've noticed in the data that you presented with LDL apheresis that there was almost like a breakdown between the patients that responded very well and patients that did not respond, that were practically unchanged. Do you think that's reflective of a different FSGS pathophysiological path? What's your hypothesis of why that's on-off type of response to treatment?
I think it could be a different etiology, different pathophysiology. It could be they were sort of like more fibrosis if the biopsy sort of like starting a little bit late in the process. I think those are probably the two things that come to my mind.
We have a question from an anonymous attendee that said, so have had good response in patients with a cocktail of plasmapheresis, rituximab, and so wondering that if no head-to-head trial, how could one make an argument in favor of LDL pheresis over conventional pheresis? Plus, also it will be a challenge to get it approved by the insurance.
That's a fair question, and I think this is the idea of doing the study, to have a more solid answer about the benefits of LDL apheresis. What we are trying to see now is what's basically the response rate? What's the percentage of patients that would achieve complete remission, partial remission? At one point, I agree there should be head-to-head study compare plasmapheresis to LDL apheresis. But that's, I think, that will come later after having the initial after the initial one-arm study that they are doing now.
Yeah. No, I think the challenge is obviously with the rarity of the disease, especially if you're really looking at primary FSGS recurrence. So, I think maybe us as a nephrology, as a transplant group, we need to be more united in our approach. I think it is probably a call for action. It should be a call for action for maybe uniting all these cases that are rare under an umbrella of an observational study is something similar like Neptune, something that can allow us to learn from these cases in a more statistical setup, epidemiological better setup that can inform decisions and potentially inform future head-to-head trials as suggested here. So yeah, I think there's more we can do. We keep complaining about how rare this is and heterogenic appearance and so forth, but I think we need to unite our cases into observational umbrella of some sort.
Agree, totally agree.
Right. I don't see any other questions from the audience. I'll wait another few seconds, but yeah, I don't know, maybe any closing arguments from you, Dr. Alhamad?
No, I truly enjoyed the discussion and all the questions. I think there's a very fair argument about comparing plasma apheresis to LDL apheresis, and that's the idea about pursuing further evidence in this study. And it's just need to have more collaborative efforts to highlight maybe better tools for diagnosis, better looking at the further deeply in the etiology factors, and just like as you mentioned, as a transplant community, to have certain guidelines that will help overall in treatments and getting us all on one page.
Well, thank you very much. Thank you to our audience. It was great. I enjoyed your presentation as well as the conversation that we had. So have a good night, everyone. Thank you so much.
Thank you.